So, this journal club is about the article Emergency Department Physical Therapy, an important tool for emergency physicians. And it's not like a research article per se, right? It's more of an invited commentary. And it's from May of 2021 from an emergency department in Texas, like we talked about with Rachel's from this hospital. And I just thought it was a really good way to kind of end the year because I talk about why physical therapy is beneficial for patients in the emergency department. And I talk about why it's important that we're there and PT satisfaction and provider satisfaction. But I actually really like this physician framing that physical therapy in the emergency department is a tool for emergency physicians. Now, I don't want us to think about ourselves as an intervention, right? I want to think about us as a profession. So, are we a tool for physicians? I would argue no. I don't want us to be seen that way, but I also think there's a lot of value in being seen that way, at least initially. So, if we're an adjunctive tool or resource that emergency physicians can call on, I think that's how we kick our way in through the door to kind of seize those opportunities to show really who we are as a profession and who we are to benefit the emergency department, the hospital, the community, the patients, the providers, and the team. So I'm interested in hearing from you guys, like, what are your thoughts about this commentary?
I'll tell you, the one of the takeaways for that I got out of it that I really loved was a response to this concept of scope of practice
Yeah.
and how so many physicians, first of all, don't understand PT scope of practice, but assume that there are many different types of care that are outside the scope. And while it may be true that physical therapists are not directly involved in life saving care, maybe in this environment, and correct me if I'm wrong because I'm not in the ED. Um, However, patients arrive at the ED with complaints or presentations that are also not life-threatening.
All the
And so
time.
that's where we're useful. That's where we're going to help ease the burden on physicians. And I feel like the same thing in primary care. And
Yes.
that's what I've been trying to get across to the physicians that I work with. And they look at me like I've got six heads. They still like so I'm not delivering the message very well. But anyway, that was one of the really valuable things that I got from this was like that's the response.
Yeah, and then there's this concept of like we don't need PTs in the emergency department because the emergency department is for emergencies, right? And Megan always says there's not a physical therapy emergency, but there should be physical therapists in emergencies, right? And I think this is a really good example of that. The other thing is like people are going to continue to come to the ED for not emergencies forever. And there's a lot of reasons for that. Some of it's access, some of it's social determinants of health, some of it's health literacy. Sometimes it's just because it's the thing that's open and you don't know what to do. Sometimes it's because you Googled something and you scared yourself and you don't know where else to go or what else to do. Like, for example, we had a patient this week who's been to the emergency department 4 times in the last 2 weeks for low back pain. And the providers were like, why does this patient keep coming back? And I had not seen this patient before. And I said, well, why do you think they're coming back? Like, what was the recommendation you gave them when they discharged? And they said, well, we told them to follow up with outpatient PT. Great. The patient has no health insurance. So you've given them a plan of care that's not useful to them and a plan of care that they can't access. And so their function continues to decline, and you've not done anything to intervene. And so they're going to keep coming back here to see the physical therapist because you haven't made a better arrangement for them, and they're not getting help. And so they're going to keep coming until they get help because this is the only place that will help them. And if we're not being helpful, they really have nowhere else to go. So continuing to evaluate those patients, trying to figure out what we can do to actually bridge that gap, I think is huge also. Megan, I know you have an opinion on that.
I have a lot of opinions on a lot of things. Um, I like what you said about being a tool, and I think while at this point in my career, having been in the ER for, several years now, I don't like that mindset. I understand where it's coming from. And I
Right.
think when you are new transitioning into the ER, or you have physicians who are new to utilizing PT in this practice space, it's okay to have that mindset because you really want them to understand that it's a group effort and
Right.
that your lens is going to be different despite looking at the patient and even doing very similar exams in a lot of ways. The way that you look at the person is going to be different. You're going to see other things. You're going to ask questions differently. You're going to get a different answer. But to Elizabeth, to your point about not being life-saving, I would say that you probably will catch more of the missed near death ones because of the way that we do the exam for a patient in the ER. So physicians, bless them, will look at a person on a gurney who's laying flat, not moving. They're in one position. They get labs, they get imaging, they get vital signs, they get all these things when they are laying down. And then suddenly you start to move them. And now the complaints start coming up, and you're like, that doesn't make sense. And that's when you really start to, as the professional, pick out what does it actually look like. And you're like, this is not right. You're missing something here. And this is what I see. And so I've caught so many. And Rebecca, I don't know if you've had the same experience. I would imagine you do, where you've caught something where you're like, guys, you are missing a huge component of this
Yes.
just by moving the person.
Right.
And even if you're doing the same exam, but
Well, and I think
Megan,
the
can you give
bottom
an
line of
example?
that, we can give you many, many examples, but I think the bottom line of that is if you're the musculoskeletal specialist, right, we're going to pretend that that's all we do. Let's just pretend that that's all we do, because that's really the scope of this commentary. All we do, we're the musculoskeletal specialist, absolutely nothing else. If you are the specialist at that, you can rule in a musculoskeletal condition very quickly, but you can also rule it right out. And they're not great at that, right? Well, they're like, oh, low back pain. It seems mechanical. Okay. But then when you are really the expert at that and you've seen thousands of normal, those abnormals turn up very quickly. So, some examples in my practice: spinal abscesses, sepsis, fractures, Guillain-Barré, miscarriage, kidney stones, like metastatic peritoneal cancer, pathologic fractures, so many different pieces of things. One guy was just like, looks so bad. I was like, he just looks really, really sick. And they were having me see him for back pain. I was like, why are you really here, my guy? Like, what are you here for? And he's like, I feel like I've been hit by a truck. And so I said, I think he's got like infectious process going on. This is not musculoskeletal back pain. This is like systemic illness. But because he was a 30-year-old guy who had like a mechanical complaint, who had like a lifting injury recently, like they just kind of like put it in the musculoskeletal bucket because they don't have the nuance around that we do. So really easily able to pick that up. When you broaden our skill set to everything that we truly do in the emergency department, you're talking strokes, heart attacks, seizures, cord compression, like vitals instability. I mean, so many different things because we're really good at what we do. And so it's that concept of being the right provider at the right time. And this article says, and it says, some may argue that EDPT evaluation is not within the scope of emergency medicine, and that this is solely the responsibility of the primary physician. But why? And who decided that? Who decided that they had to know everything and figure everything out, right? Their job is to save lives, to make people feel a little bit better. But the article also says that the people seeking musculoskeletal care in the emergency department exceeds 11 million annually, and that the only tools they have to address that are an orthopedic referral, a prescription, an over-the-counter medication, or imaging. So they are getting a diagnosis of 11 million people per year that they don't have the tools to manage. And if that were another disorder, if you think about say this was sepsis and you had 11 million people coming in with sepsis and you only had physical therapists there to treat sepsis. And we can't prescribe anything, we can't do IVs, we can't do any of that. That would be a huge problem, right? You don't have the right provider to manage this massive influx of patient complaints. So by getting the right provider at the right time, you're now addressing 11 million complaints with the right provider, the right intervention, and the right management. So I think the mindset shift here is, do you have the right tools for the job? If that makes sense.
They don't.
And I would argue that emergency physicians know that and they want to be better and they want to make people feel better. And they hate it when these patients come in because they don't have anything they can offer them.
Just a side note for my practice. So, our physicians love us, they just forget about us frequently. But actually, one of the things that they have told me, I'm sorry, please hold.
Life work balance, man.
Sorry, dog children.
It's all good.
um, yeah, so they don't want to consult me because they're afraid that I'll be upset at the consults. They're like, oh, because every other service that they consult is frequently trying to tell them not to consult them.
Right.
I'm literally down there saying, like, consult me for, at this point, consult me for whatever you want.
Everything.
I'm
Mm-hmm.
like, I can't wait to get to the point in time where I'm talking to you about appropriate versus inappropriate consults. Right now,
Right.
just give me everything. Like,
Well,
um,
and I think that's an issue with the healthcare system in general and with PT specifically, that we are constantly looking for reasons not to see patients instead of the reasons to see patients. That happens in acute care all the time. And I've been having that conversation a lot lately. Well, I can't see that patient, their blood pressure is elevated. I can't see that patient because their hematocrit's 1 point below normal. Like, I can't see that patient. They had their x-rays not done yet. I'm like, well, we shouldn't have ordered an x-ray in the first place. There's no reason to wait for that, right? So thinking about that too, that right provider, right time, and the right reason. And the best person to know if a patient needs physical therapy is the physical therapist. And so you're absolutely right to tell them to consult you for whatever, and you'll help sort that out.
yeah, I just thought it was interesting.
But you're right about the other providers, right? They don't want to come down. They don't want to be bothered. And we have a lot of services now. This is another tool you can leverage, is our admitting teams will now say, we will not come look at the patient until they've seen the physical therapist. So those are going to be your older adults that are failing. Those are going to be your neuro patients. Those are going to be your ortho patients. Like, so those admitting services do not want to admit patients. They don't want to come down and consult. They don't have the bandwidth. They don't have the space. The hospital is full. Have the PT see the patient. If they can't discharge the patient, or if they have more concerns, then we'll come down and evaluate that patient. So that's a big culture shift for your entire hospital when you start becoming one of the gatekeepers to the door to the hospital.
I
That's
mean,
been
I like
pretty,
that kind of power.
yeah, that's, it's like scary to me. I mean, I've made it happen multiple times, right? Where, and then I actually made it happen for good reasons, but it was someone that I knew, right? And the family member was like, you're the reason why we were admitted to the hospital. I'm like, absolutely, I am. Like,
Yes.
absolutely. Hi, Ben.
I think it also helps though, like for new grads and new practitioners, it really helps that point of being not necessarily a gatekeeper, but the gatekeeper really helps you develop your professional voice. You know
Yes.
how to present it, you know how to present it in a way that they understand, and you really know how to own your practice, which I think is super helpful. But it's a process. You got to get there at some point.
And that's the difference between managing patient care and consulting on patient care. And that's a mindset shift I'm pushing so hard for PTs in any setting. We're not an intervention, we're a profession. We manage patient care, we don't treat people. And that's moving from that technician mindset to that doctor mindset. And that I think is how our profession is going to survive. I don't think we're going to survive if we keep waiting to be told what to do.
Or
That's
asking
another
permission.
soapbox. Yeah.
Preach.
But I also think that some of your best allies in the emergency department are the physicians. And so I love this article and being able to like take a look at it and be like, look, we can help you. Here's how we can help you. And this is just one way we can help you.
I also am curious, side note on this, I'm curious like when this article was written right around the time when I gave my first presentation to like all of the ED physicians. And so I'm really curious if that like made any difference in this article being written.
I bet
That's it.
it
That's all I'm
did.
gonna say.
I think you should just own that.
Just to go with yes.
Just take
Yeah.
credit for that.
It's literally the same year we started our program, and like I think we presented in March. So
Well, and I
accepted.
really want to acknowledge you for starting a program during a pandemic.
Yeah,
Um,
absolutely. I had
I
a lot of good support. So
when we talk about life work balance, my boys are out there cooking and something smells like it's burning. So I'm gonna go and just make sure my house is not on fire. You guys keep talking. I'll be right back.
That's so funny.
Rachel, can I ask you a question? Um,
absolutely.
how did the idea of presenting to the ED physicians come about? Whose idea was it? How did you get buy-in? How did you get people on board? And, because, there's I think the marketing piece is really important. And I don't know, I'm not sure how to do that. Other than, I've tried to provide literature, evidence-based or, peer-reviewed type stuff. There's plenty of evidence out there. And they're like, I'm not gonna read this. I don't have time to
Yeah,
read this, so I'm not sure the best approach.
absolutely. I feel like I am slightly unique in the sense that I had really great support from my management. Like I kind of was chatting about it for a while and they're like, no, no, we want you to do this. We're actually going to hire a specific PT position to like accommodate the later hours of the ED. So like I had really good support from my management, which I think is a big hurdle for a lot of other therapists. And then as far as like getting to present to the ED providers, another unique thing we had is we were actually we were trying to get certified as a geriatric ED as well. So the ED providers were looking for a therapist to be part of the multidisciplinary team that's required for that certification. So it it wasn't like I was just like beating on people's doors, being like, let me in, let me in. I did have a unique opportunity where I just happened to be in the right place at the right time with a lot of motivation and gumption. Um, but that initial, I mean, I'm not gonna lie, that initial presentation I felt like didn't do anything. Like they were like, oh, this sounds great and like cool, great. And like nothing happened. It was like a year later, I did another presentation with actual like case examples from like good cases that we'd had. And I started to get of like, oh, like connecting the dots of, oh, this is maybe what we can do. But again, still like 5% of what I want. And then finally, this past year, I did another presentation again. It's just constant. It's just like, talking until you're hoarse. Um, but this last one was super beneficial and way better of an impact than prior ones. So it's like it's starting to happen. The snowball effect is starting to happen. I feel like it's just such a slow journey for us.
Well, I will tell you, I think you should come to our How to Create a Thriving Practice in the Emergency Department course because it's 2 days on how to fix that a lot faster.
Right.
And some of it's data based and some of it's like how to make the behavior change. But I'll tell you, my best tip for you is that every emergency department has an algorithm for how they manage different things. And if you are not in the algorithm, it does not matter how many times you ask them to consult you
Yes.
because they live and die by the algorithm.
Yes.
And otherwise, it's out of sight, out of mind. And I understand why they are algorithm based. And if you've read the Checklist Manifesto, fabulous book. If you hadn't read it, it explains a lot about how healthcare is moved because of checklists and how things are improved and there's less unwarranted practice variance and like it's why they do the surgical timeout and like two identifiers and all of those things and how they like greatly improved healthcare mistakes and things like that. So a lot of healthcare has gone to this algorithm checklist based thing, which is great from the perspective of you now have people who are theoretically following best practice all the time. And it's practice that all of your providers can agree on, it's practice that your facility can agree on, but there's so much space in those algorithms for physical therapists. And if you don't get into that algorithm, it will not survive. And if you leave, Rachel, it will not survive because that's the other problem is physicians will get really used to you. And then when you're gone, they'll just stop consulting because there's a difference in PT practice, there's unwarranted practice variance, and they're gonna just get like, well, if Rachel's not here, I'm not doing it. It's not worthwhile. So it's that algorithm change, that culture change, and that's how you get that sustainability of practice. Otherwise, it just will not happen, especially if you're at a large teaching hospital where you're constantly turning over residents, you're turning over interns, you're turning over fellows, you're turning over attendings. It will be this constant chasing your tail situation until it gets into their workflow. So, like
It's a
one
big,
example of that, our vestibular workflow, if a patient comes in with dizziness, it's like yes, no, they go on these different pathways. And ours is like, do not give meclizine, consult PT, unless PT not present, and then it's got another whole thing. But that's just one example of how you can get in that workflow permanently. I don't
Yeah,
know
I
if
think
that's
yeah.
helpful or not.
No,
it's
it's
really
good. It's in the
awesome.
works for our hospital, so
Yes.
it's slow, but it's
Yeah,
coming.
I love that. I'm so happy to hear that. So many people are like, what algorithms? And I'm like, oh, let me
I
help
had to
you.
like ask around though to like find, I'm definitely just a very like pushy is not the right word. Aggressive is also a negative connotation. Whatever. I am
Assertive.
passionate and I am
Assertive.
assertive. And I'm going to keep asking questions until I get what I want.
Yes, ma'am.
And so, yeah, I finally found a couple of the physicians, the ER physicians who are actually on the informatics side of things. And so they're my ticket, but it's just still very slow.
Do you have Epic?
Yes.
Epic has a button that will show you all the algorithms.
Oh, golly. Epic button. Yeah, all right. That sounds
There
great.
is a button, like literally on your Epic, that you can click and it'll pull up all of the like chest pain pathway, low back pain pathway, abdominal pain pathway. And you can sit and look at those and be like, this is where we need to put PT. Now, I'll tell you, beyond that, it's really difficult. That part's easy. Here's the algorithm, here's where I think we could fit. But then you're going to have committees and meetings and like all this like other nonsense that goes with that. But it sounds like you're well up to that challenge.
It ebbs and flows.
No, that is heard. Megan, I feel like you wanted to add something to that.
I was just gonna say before we built out our PT pathway, um, maybe for like Elizabeth, who's really just getting started with the foot in the door, I think the thing that worked out the best was attending rounds if you have
Yep.
that ability. And then I love a good captive audience, but I didn't put out published literature in the bathroom. I posted a sign saying, if you have this complaint, consult PT, because you're never going to have more captive time than when they are sitting on the toilet doing nothing but reading whatever is right in front of them. And I just had a cute little sign for them to be like, oh, consult PT for this. Perfect. I don't have to do that.
Yes. And I round with journal articles, or if we have a case where it's like dizziness and it's like they are like, sure, it's BPPV, and then I'm calling a stroke alert. I'm like, here's the most updated guidelines. Here's an article I think you should read. Here's the like take home points of it. And I always make sure to use like physician references because I still think there's this little bias that like maybe PT research isn't quite as robust as physician research. So I use ASAP a lot and the American College of Emergency Medicine guidelines, the Grace 3 guidelines. I'm like pulling out their best evidence and using that to help nudge them in the right direction as well. And I think too, once they really understand your skill set, it's a lot different. But physicians just don't know what we do, and that's really on us to show them. And I have PT students who say, well, how come they don't know what we do? And I'm like, you're figuring out what you do. They're still figuring out what they do. And you can't expect them to know all of this about the human body, about all the disorders, all the medications, all the testing, all the lab values, and to expect them to have this concrete, robust idea of what every other healthcare professional also does. I would argue we probably don't know the full scope of what they do. So I have patients that say all the time, well, they didn't do anything for me. They talked to me for 5 minutes. And I'm like, you have to understand the amount of training that they have to be able to make those decisions and that plan for you in 5 minutes is insane. And it's actually kind of a flex. It's not necessarily a bad thing. So I think we need to come into it with this perspective of they don't know what we do and that's not their fault. And just like the best person to decide if somebody needs physical therapy is the physical therapist, the best person to teach them what physical therapists do are the physical therapists. But I've had docs that say, how come I had to learn you were a doctor on Twitter? I'm like, oh, we all are. Let me tell you a little bit about our background, our training, my scope of practice. And then we had a shared patient, and I said, hey, can you clear the cervical collar? Because I feel like we could probably get this patient out of the collar. And he said, you're a doctor, you can do that. And I thought about that for a minute, and I was like, yeah, I can do that. There's absolutely no reason why that's not in my scope of practice. If that patient came to me with direct access, I would feel 100% comfortable putting a collar on that patient. I would feel 100% comfortable sending that patient for imaging or not sending that patient for imaging. I would feel comfortable sending that patient to the emergency department or not. Now that they're here, why am I all of a sudden not comfortable making that same level of assessment? And so I think that's been part of that journey for me too, is seeing our skill set in a different way and seeing the opportunity we have to collaborate with the physicians for shared decision making to really enhance the care that patients are getting is really amazing. And you're in a perfect spot to do that, Elizabeth.
Yeah, I think, it's right now it's trying to find ways to I am co-located, but it's finding ways to interact with the other staff. It's a big office. There are a lot of providers, and everybody kind of works in their own little space. And I think one of the other issues is how much time, face time. So that was another question I had for some of you is when you first started, Rachel and Megan and Rebecca, when you first started, was it, you were there 40 hours a week or, do you need that kind of face time? Because I'm trying to build this on kind of a very abbreviated time. There is another therapist, but again, her ideas about what top of scope or what the role of PT in primary care are a little different than mine. And she brought me on board. She's on the leadership team, and I'm being very much gate kept. I'm being asked to, I'm asking frequently, can I be introduced to? Can I attend this meeting? Can you remind me when rounds are and maybe I can get that because rounds are virtual and can I please get the Zoom link? And I get kind of ghosted and I was told at the primary care seminar that I should find a new place, but based on some of these things, but I'm not ready to give up quite yet.
Yeah, I
That was
think
a lot. That was a lot of questions, but I'm just kind of really I'm really passionate about it and I feel like there's so much we can do, particularly because I am in a rural environment and access to care is so, so difficult, as it is everywhere. Everywhere it is, even in cities and everywhere. But
I
uh,
love that we're having this whole conversation because I've been thinking about it a lot. I'm going to teach somewhere next week as like an assistant, but part of it is primary care content. And uh, the idea of primary care that I have been presented with and the idea of primary care that I have are very different. And I think that a lot of primary care is being taught as like advanced MSK. And that's not primary care, that's ortho light, or not ortho light, but like ortho senior, like it's MSK3.
the
And
screening, general health
that's
screening, yeah,
oh,
that should
right.
be in
And
every
that's
course.
not where we're at. And then today I had my mammogram and I went for my physical and I was sitting there thinking like, they're not doing anything for me. And my physician was even like, I feel like I shouldn't even charge you because I'm not going to do anything for you today. And I just thought, there's so much to be done, right? Like, you didn't ask me about diet and nutrition. You didn't ask me about sleep. You didn't ask me about exercise. You didn't ask me about wellness. You didn't ask me what my goals are. Like, and that's such a PT mindset, right? Because the primary care model is so focused on sick care and how we can help you when you're ill, that there's just no real focus on preventative care or primary care or wellness. And then I think about my physical therapist who I've been seeing for a year for my Liz Frank injury. And I thought, he has managed my primary care so much more than my physician has. So if I went in there and I'm like, you know what? I hurt my wrist. Can we look at my wrist today and not my foot? Absolutely. Some days I might have needed something for my neck, or he'd be like, you need to get this tested, or like, how much water are you drinking? Like, so many of my health concerns have been 100% held, owned, and managed by my physical therapist and not my physician, that I truly believe our role in primary care is wellness, and then we consult with physicians around illness. So that's where I see your opportunity. And in response to your question about like hours per week, physicians will use the tools that are consistently available to them. And so if it's not there all the time, it's not there because you're asking them to take on the additional mental load of, we have a PT on Wednesdays. Wait, what day are they here? Or what time did they leave already? Like, you're either there or you're not there. It's like having like a photocopier. The photocopier is always there. They know they can use it whenever they want to use it. If it's not there, then it doesn't exist. So when I tell people about the emergency department, like trying to do this on-call model, trying to come in and out, trying to only have certain hours, it really isn't very successful because they want that service to be a service that's available to them. They can page orthopedics 24 hours a day. If they can't page physical therapy 24 hours a day, it may as well be 0 hours per day. So it's just different. So the best answer is the PTs should be there when the patients are there. Otherwise, it doesn't matter. So consistency, I think, is key.
I knew that was going to be an issue. I mean, that just seems intuitive. So, we're trying to build a team to do it, but
And the problem is, like, your rehab director, your rehab manager, they'll all be like, well, you have to build it up. You can't just go down there. You have to build it up until it hits this threshold, and then you can be down there.
yeah.
And I'm always like, no, 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 no. You have to be down there, or you will never hit that threshold. So it really is a different approach, but they are used to consistency.
Yeah, I think for me it was more about the face to face. For rounding, even if none of the patients seemed like they had like a direct PT need, seeing my face in their space, they started to recognize over time. And even if I was only coming down early on and in the consult model, um, they still knew my face, even if they never knew me. And then as far as the relationship building, again, because it was a teaching hospital, like we were using direct names. It wasn't Dr. So and so unless they were the attending. because I needed it to be more personalized. They needed to know me as Megan, Dr. Mitchell, and then I would talk to them as Doug or Steve or Cindy, and they would be that person, and it would sort of break down this sort of hierarchy barrier that sort of exists between physicians and outliers who aren't normally in the ER. It worked for me. I don't think that's a good strategy for everybody, but it worked where I was at.
Any other questions, comments on this commentary? Ben, do you have the physician 411 on this? Is anybody even old enough to know what the 411 is? I can't believe I just said that. Rachel's like, no, I have no idea what you're talking about.
I know.
So,
You do?
I that's really funny. No, so Nikki's perspective has always been, what are the grenades? What are the energy vampires of the emergency physician world, or what do they have the least confidence in, or the most fear of litigation around? And more often than not, it was the non-specific low back pain. That they just decided to come to the ER, whenever it was, and it's been 6 months and it's achy, but maybe they've had some change in their bowel and bladder, things like that, or this dizziness that's kind of been intermittent, like all the things that, we can spend more time and get in and dig deep and potentially offer, you know, BPPV, like a fix, or in these other things, steps towards a path towards resolution, that a physician who's juggling a tremendous number of things wouldn't be able to either spend the time or necessarily have the expertise to help with. And I think that's always the leverage, is like, let's take some of the things off your plate that you don't enjoy having on your plate. And then the consistency is something that you've all already touched on, but in the level 2 trauma center that we first had PT serving in the Sacramento area, they'd previously been able to consult PT, around the clock, not around the clock, but in normal hours. But they never knew who they were going to get. And once it was 2 guys, and those 2 guys were the ones that would consistently go for consultations, and they actually had specific time designated to be in the department. That's when their program started to expand and have more confidence. And unfortunately, one of those guys left. They changed the schedule, they created a rotation, and the program fell apart, even with good physician support. So it is all those things. It's justifying the FTE. It's getting the right physicians on board early who are advocating for the time, for the PT to be designated and to stay in the department. I think the one other kind of piece that I wanted to touch on is, I guess to an extent, the informatics side, which has also been mentioned. But I'll put a plug in for the American Medical Informatics Association has a 10 by 10, a 10-week program in biomedical informatics through OHSU. And that can help a PT, speak the language in informatics, have some more credibility with the physician partners, look at throughput of the emergency department and figure out, well, if you can't have a PT all the time, when do you have the most arrivals? Is it always the Monday after holidays? Can you do a pilot of, like, let me just have a PT for 12 hours the Monday after that holiday, when we know the volumes are going to be astronomical, and can we have that person offload the other providers to an extent? And then if that goes well, what else can we do? So this kind of pilot initiative is something that can be very helpful.
Ben, is
Sorry,
that
I
the
was sitting on some of those.
biomedical informatics at OHSU?
Yeah, so I would go through AMIA, the American Medical Informatics Association, and it's the 10 by 10 or 10x10 program. And that will link you to OHSU. There are a few different organizations that offer 10 by 10, but the one that felt most relevant for me was the OHSU one. I did it a summer ago, 2 summers ago.
I'm just gonna put that link here in the chat.
Oh, thanks. I'm still on my phone after getting out of the car. Thanks for.
Does anybody have any other questions or comments or anything they want to bring up? I want to be respectful of your time, and we're almost out of time.
I know I don't work in the ED. I do work in acute care, and I'm at a rural VA, so we're very small. I'm the PT for the skilled nursing facility on our campus, as well as our acute care floors and the psych ward, and pretty much jack of all trades. We
Top of
did
scope,
just in
top of scope.
absolutely, and obviously my focus is geriatrics. But I think when you start showing success stories, when I joined this particular VA 4 years ago, therapists in the past apparently said, "Oh, they're at their baseline, they don't need me. They're at their baseline, they don't need me." And so I had to, yeah, exactly. I hate that phrase, the baseline. Um, and 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 so I think you just have to you crawl slowly. You plant the seeds and you hope to water it, and you might get a couple of things growing, but I think you just keep moving forward with showing the value. And that's the thing. The value of what we do is one patient at a time. And so while
Yes.
we all probably have these really, really big goals, it takes a lot of time. And, at the very beginning of this, I was, complimenting Rebecca. I was the state advocate for Colorado, and I could not get anybody in the PT profession to listen to me about being collaborative in our state. And I'm like, I'm not trying to sell you anything. I am not in competition with you for anything. I think we're part of the same team, and I pay dues to be a part of the same organization that you're the, fill in the blank. And I could not get a return email. So it took me several years before I finally met Rebecca, who introduced me to, and so it just have to be tenacious and just keep going saying, I'm going to do the very best I can do. And eventually people will realize I'm doing a really good thing here, and they're going to want to be on my team. And so, that's just my experience, is that I just keep staying in my little world going, you're going to want to be a part of me. I can just feel it. I'm just going to keep doing what I do. And you're going to eventually, everyone's going to be like, Elizabeth, where have you been all our lives? And you're like, I've been here for 5 years. And you're finally going to get some traction. So, the smaller things add up to big things. You're just going to have to be patient. So, anyway, that's my comment for the day.
Yeah, I love that. I love that. And one thing that I heard lately is that the extraordinary is really in the sacred ordinary. And the more we keep pushing our extraordinariness through the ordinary things that we do, I think we're going to be really successful. So, anyway, I think our profession's amazing. I think it can go in so many different ways. I'm excited to be part of it. And I'm really happy you guys all chose to spend some time here tonight. Just to let you know, next journal club, I don't have a date yet, but there is an article, and I'm gonna put it here at the citation in the chat just so you have it. It just came out in PTJ last week. And Dr. Susie Ryer is a geriatric specialist who has done tremendous amount of research about physical therapy and geriatrics in the emergency department. And there's also going to be a part 2 to this article. I just spoke to her today. She and I will be presenting at CSM together with some other PTs about discharging older adults from the emergency department. And one thing, I was at a course she was giving a presentation at a couple of weeks ago, and one of the things that she said that impacted me the most was, she said, one visit to the emergency department can change the trajectory of an older adult's life. And that gave me chills and made me feel the real responsibility of that. And so I'm really looking forward to having her help facilitate that next journal club. She's been on the podcast before too. If you want to hear from her, she's fabulous. She also had an on-demand CSM presentation last year that you can find as well on geriatric certified emergency departments and the data that they're finding.